just a failure to have that initial discussion with the patient about what signs or symptoms to look out for if you're not improving, if your condition's not getting better, or if it's a problem with the follow-up system at the practice. So I'm talking in a general practice setting. It might be that, the abnormal results have come in. I've seen a couple of cases like this in the past where perhaps you've sent the patient for a fecal occult blood test. You're screening for colorectal cancer. It comes back positive, and then for one reason or another, that test just sits there. It doesn't get seen by the GP, or the GP sees it and then forgets to recall the patient. So a lot of our recurrent claims seem to be in relation to a failure to follow up.
Yeah, if I could just follow up on that a little bit, a couple things. So we're talking about why these diagnostic errors happen, and certainly one big category are the cognitive things that go wrong. And in that dimension, you're thinking about, knowledge. Do I know the disease? And there's 10,000 diseases, for goodness sake. It's hard to know them all. Do I have all the data? And really the biggest piece of the pie is, am I putting everything together correctly? Am I synthesizing the information? And that's where these cognitive biases come into play. But you brought it up, Owen. There's also, we call them affective biases. So our emotions and our feelings are very important in all of this and can sometimes get in the way of making a diagnosis. The classic example, James, you're an ER physician, you may recognize this. There are certain patients who tend to overutilize the emergency room. For example, they may be an alcoholic who's in there every week complaining about this or about that. And you may have some feelings about that patient if you're called to see them, that he's wasting your time. And why doesn't he follow up with his GP like I tell him? So these negative things affect how careful we are in analyzing that patient. Or it may be a patient who's antisocial or overweight or elderly. We all have these little unconscious biases that come into play and can undermine how effective we would like to be.
So it's a nice little summary of some of about cognitive bias and how we use heuristics in decision making. Have you got any kind of take-home messages, Mark?
Yeah, so I wish there was a course in medical school on all these cognitive biases, and there isn't one right now. So that's why these broadcasts are important. If physicians could, I think, realize that they're human and they're predisposed to these things, I think it would help reduce the risk of diagnostic error, because there are tricks you can use to avoid them. So if you know that, for example, this premature closure is something we're all predisposed to, you may take a diagnostic timeout and try and make that differential diagnosis. If you know that affective bias may lead you down the wrong path, you may try and immunize yourself, and before you go into the room to see that alcoholic frequent flyer, you say, I'm gonna be really on my toes and make sure there's nothing serious going on, which may be the case every once in a while. So I think knowing about these things is a good thing. There's a big debate right now about whether you can actually prevent these biases. So what if there was a course on biases? Would it prevent you from making these mistakes? And a lot of people say that you probably can't prevent them because it's human nature. We're hardwired, and we'll all make these mistakes no matter how much training we have. But I think the answer to that is that even if you can't prevent them, you can at least recognize them. And if you can recognize these biases in time, you have the opportunity to intervene before there's harm. So I try and do that in my own practice, in my own thinking. I see that I still make cognitive mistakes, and I see that I'm still biased, but I'm more attuned to it. I say, oops, I should have thought a little bit more about that decision I just made. And that's very valuable. I think that would help prevent some diagnostic errors.
And I think prevention of diagnostic error is what we're going to speak about next. We identified that we've got reasons why we make errors, but can they be prevented? And Mark, do you have any, strategies that you have found useful in preventing diagnostic error?
Yeah, so that's a great question. And there's strategies I think that would be helpful for patients to know about and physicians to know about and healthcare organizations. So I'd like to just go over some of those quickly. So let's talk about our practices as physicians and what we could each do. Definitely, I think the number one thing is to practice reflectively, to stop and think, to get that. We want to always be checking on our subconscious thinking by rationally considering what's going on. So if you can take that diagnostic time out, it doesn't take long, just a few seconds, a minute. How did I come up with that diagnosis? Is there something that might have biased me? You know, a very frequent thing, the patient will come in and say, you know, I think I have influenza. And you say, yeah, I think I agree. So whenever the patient tells you the diagnosis, or even a doctor who saw him before you walked in the room, you have to say to yourself, I wonder if that's biasing me, and I really should think this through on my own before settling on a diagnosis. So think reflectively, stop and think. That's great. Another major recommendation was actually the number one recommendation in that report from the Institute of Medicine, was to make the patient a partner in the diagnostic process. You know, the old model of medicine was the paternalistic one, where the patient would come see us and we'd tell them, you know, what's going on, and the patient would go on their way. But in reality, diagnosis is not a certainty. There's always things that keep us from being 100% certain. It's just too complex. There's too much uncertainty. It's always just a probability. So I think what we'd like to see is doctors be forthright about that. Here's what I think you have. Here's what we're going to do about it. But if your symptoms don't resolve, if you don't respond to treatment, come back and see me, and we'll rethink this, because there are other things that are possibilities. So making the patient your partner is huge. And it gets to a third thing that we recommend, which is better follow-up. When we talked about that, how important it is to follow up with your patient. One thing we're very happy to see in emergency room practices is the ED calling up the patient a day or two later. How are you doing? That's just so important and very valuable. It's good for public relations, but it's also good for catching diagnostic errors. We'd like physicians to get more second opinions. Second opinions are great. Fresh eyes catch mistakes. So somebody who hasn't seen the case before, thinking it through on their own, excellent way to catch diagnostic errors. We'd like to see physicians use decision support resources. We'd like to see them make a differential diagnosis in every case. And we all know how to do that. You may not need decision support, but there are some terrific products out there now that are available on the web that will help you with the differential diagnosis. That just takes a few seconds. You put in the key findings in the case, and it gives you, here's 10 things to think about within a second or two, which is great. And you don't even have to do that. You could just use a simple checklist. There are checklists that can be downloaded from the website of our Society to Improve Diagnosis. And for the most common 90 symptoms in primary care, there's a little checklist. Did you think about this? Did you think about that? So those are the things physicians can do. Do we have time to talk about what patients can do?
Yes.
All right, let's talk about that. So we already talked about being part of that diagnostic team. That was a recommendation from that IOM report. And this is a big responsibility. If you're sick, you kind of don't want to take responsibility. You want to be taken care of. So it's kind of a new paradigm, but we think it would be helpful. There's lots of evidence accumulating that patients who are engaged in their healthcare have better outcomes. And if you're engaged in your diagnosis, it could be a good thing. You need to ask what else it could be. You need to follow up, as we've discussed. If things aren't panning out, you have to get back and give the providers another chance at things. So patients can play a critical role. We'd also like them to keep all their own tests. We have a big problem in our country, and I'm sure here too, that when you go to the doctor, you assume that they have all your records, and they may or they may not. So if you're clever, you'll keep all of your own records and take those with you when you go to see a new provider, so that they can take a look at what's gone on in the past and know what's going on. So those are the big things for patients.
And how about the families of patients? I know within pediatrics, you always trust your mum or dad thinks something's wrong with the child, even if you think they're okay. Usually mum and dad are often right. Is there a role for families to be more involved with their, son, daughter, mother, grandmother's care?
Yeah, if you talk to patients who've been through medical errors, a lot of them say the biggest problem was the doctor just wasn't listening to us, didn't listen to what we were saying. So paying attention to what the patient is saying and what the family is saying is really, really important. And we've talked a lot about the cognitive problems. There's all these system problems too, and the biggest system problem in every study is a breakdown in communication. Oh, and I'm guessing you see that in your when you go through your cases.
Absolutely.
There was some problem with communication. And if you have a good relationship with your patient and you're communicating effectively with the patient and their family, it number one goes a long way towards helping with diagnosis, but also goes a long way to preventing a malpractice suit. That relationship is just so important. You want to develop a relationship where the patient trusts you and can work with you. Two-way street, but very important to try and achieve that kind of state.
So we've spoken about the patient, the family. What could organisations do to try and prevent diagnostic error?
Yeah, thanks. So number one, they need to take ownership of the problem. Right now, they are not. Organizations are consumed by too many other priorities. And really, if they would say, this is a big challenge, we're going to tackle this, we're going to do something in our own system, progress would be a lot more rapid. So it could be simple things like making sure the providers have enough time to see a new patient. You know, what is the length of the appointment in primary care? Very important. A lot of doctors say, if I just had more time, I would have been able to look this fact up. I would have had more time to think about the differential diagnosis. Facilitating communication, making it easier for me to get a consult or a second opinion would be really valuable. We'd like to see every healthcare organization have a good electronic medical record, which has got all sorts of benefits that could improve diagnosis and help prevent diagnostic error. One of the big ones, if you have an electronic medical record, is, of course, you have these decision support resources available to you. These products that can help you create a differential diagnosis. So those are some of the big things that we'd like to see healthcare organizations and practices start to think about.
Owen, do you have anything to add from your claims experience in regard to, I guess, preventing error?
I think we've touched on most of the big ones. So certainly follow-up is a big one, which we've touched on. Communication is a big one. I mean, I think, you know, so many times I think we see claims and complaints where we wonder, was the diagnosis missed because of an inadequate history? But also very frequently we can't tell whether that history was adequate or not because the documentation wasn't great. And I can say from my own personal experience in clinical practice how many times I've seen a patient, they've left the room, I'm doing my notes, and because I'm thinking about it some more, I've got that time out, even though the patient's left. I've thought about things afterwards, and maybe I've even called the patient back, or maybe I've thought about it for next time if they're coming in tomorrow or the next day. But I really think that documentation is really important as well, because it's not only you that will be looking at those records, it may be a colleague who might be taking over the patient's care subsequently. So I think having good, fulsome records can be essential for the next doctor or healthcare professional who takes over the patient's care. I guess the only question I might have for Mark on that point, we've talked about the issue of getting a second opinion, and I've sort of talked about communication and record keeping. I guess my question would be, how do you have any tips for doctors? So how would you seek a second opinion from a colleague without biasing that second opinion to your way of thinking?
Yeah, great question. So the worst thing you can do is send over the patient saying, I think he has disease X, don't you agree? And the best way to do it is to say, I'm sending over a sick patient and I'd like you to think about it from scratch. I think that if you took steps like that, it would cut out some of that framing bias, we call it, that is so common. And it happens in everyday practice. If a patient comes into the ER who was just seen in clinic, he'll already have some diagnoses that were suggested by the clinician in clinic, or the patient may have their own ideas, and it biases you. You're absolutely right. And I'd like to just also reemphasize that great point you made about documentation. how important it is. And the one thing that is so commonly not documented is your clinical thinking about the case, why you came up with a certain diagnosis, and did you think about other possibilities? And it'll help you the next time the patient comes back to see you, but it'll also be helpful to another provider who may be seeing that. It's very important for them to know whether you thought about other things and how you came up with the suggestions that you did.
And that's why I think the documentation of relevant negatives is so important as well. And again, something that in certain clusters of claims that we see is commonly omitted. And I think as well, some of the software that we use, particularly again, I talk from a general practice perspective, it doesn't always facilitate the documentation of your thought processes around differential diagnosis. So I guess perhaps that's something for our audience to consider as well in that context.
A colleague of ours, Gordy Schiff in the States, studied 583 cases of diagnostic error to see where the breakdown was in the process of care. And what he found was that we didn't do any of the steps perfectly. So even the simple things like getting the history, doing the proper physical exam were important sources of diagnostic error. There were breakdowns 10 to 20% of the time in both of those very simple first steps. And even though the most frequent errors were in the synthesis and thinking about what's going on and ordering the right tests, we need to pay attention to every step of the process. You really do have to get a good history. Yep. You really do have to do a good physical exam. You really do have to look at the old records and look at the labs that are available. These are all things that contribute to successful diagnosis.
And perhaps the other question I might have for you, Mark, as well, and it's something that we commonly see in our claims and complaints is, we were actually talking about it over breakfast before we got here this morning. It's just this sort of concept around occult infections or occult malignancy, this kind of concept that perhaps a diagnosis might exist, but inherent in that diagnosis is perhaps the assumption that it's not diagnosable at that point in time. And very often that's what we sometimes grapple with certain types of claims and complaints is, well, there was, was there a very small malignancy there or not, and was that doctor in a position to be able to make that diagnosis at that point in time? And so much of the legal argument and medical evidence sort of focuses on that question. Do you have any comments about that sort of concept, that perhaps there are diagnoses or conditions or stages within perhaps a patient's illness where it isn't in fact diagnosable, or is that too simplistic, too black and white a way of viewing it?
I think it's very appropriate to think about that, and it's the reality of practicing medicine that really almost every disease at the very earliest stages are so hard to recognize because the symptoms are not specific enough, and we all struggle with that. So there are many, many times when you really can't be sure about what's going on until things mature a little bit and you run a few tests, or the disease evolves to the point where the symptoms and the signs are more characteristic. Big problem. And in many cases, you still never know. And the fact that we don't do autopsies contributes to that problem. So there are so many times when we really are never certain about what the diagnosis is, and that's just how medicine is right now. The good news is that as time goes by, we get better tests. So we have tests now that allow me to diagnose things that 10, 20 years ago I couldn't diagnose at all. Lyme disease, for example. And there are many others that we now have really great tests for. So diagnosis improves by better testing, but I think the challenge we're talking about today are things that we could do in our own practices tomorrow, and not have to wait 10, 20 years for these better tests. And that's where it gets to improving our healthcare systems and these cognitive problems that we're talking about. If I could, I'd like to follow up on another aspect of what you just talked about, and that's the problem of incidental findings. So not uncommonly, you'll be getting a spine film in a patient with back pain, and incidentally, he's got a lung nodule. So it's an incidental finding. You weren't looking for that, but it's there. And it's important to make note of these things and somehow have a process to make sure that they're followed up. What we see a lot is that there are breakdowns in that process. Nobody takes ownership for it. Nobody's following up. There's no registry. There's no reminder system in place. So this is probably one of the low-hanging fruit areas where we can improve diagnosis. We need better ways to follow up on incidental findings. We need better ways to make sure the laboratory tests get communicated effectively. That's been studied a lot. Even critical lab test abnormalities don't make it to the provider 5, 10, 20% of the time. It's just never appreciated that that abnormality existed, and it's a setup for patient sustaining harm from a diagnostic error. So we need more reliable ways to make sure that lab tests make it to the provider. And one approach to that I like a lot is to not only send the result to the doctor, but also send it to the patient. There's actually a law in the States, for example, now mammogram results must be communicated to the patient. And what we found is that there are far fewer cases where there was a lapse in that process. In olden times, there were many patients who had an abnormality, they never knew about it, and 2 years later they have, end-stage disease. But by communicating it to the patient is like the safety net, and can make sure that, they can call the provider. Hey, did you see this? Do we need to do anything about this?
So maybe within health now, we typically work within teams. So how can team members work together to prevent diagnostic error?
Yeah, good question. So that's another one of the major recommendations in that report from the Institute of Medicine. And this team thing has kind of become kind of a cliche. But it's actually a new concept in diagnosis, because the way that we all practice now, by and large, there is no team. It's the doctor making the diagnosis to and for a patient. But what the IOM envisioned is, first there would be this partnership between the physician and the patient. So that's kind of a new team concept. And the nurses involved would also be part of the team. The nurses know a lot about our patients. They spend a lot of time with our patients. They are in an ideal position to know whether communication was effective or not. They're in a good position to see whether what's playing out in front of them in terms of how the patient seems and acts and behaves is concordant with our diagnosis. And if they were invited to be a member of the team, they would interact with us more effectively. We had a tragic case in the States. I don't know if you heard about it. It was the first patient diagnosed with Ebola infection who came to our country. He had been to an endemic region of Africa, came back to the States with fever, sinus pain, headache, came to the emergency room, told the nurse this story, and the nurse got the history that he had just come back from an endemic region in Africa. But the physician, when he saw that patient, didn't ask about a travel history, didn't read the nurse's note, didn't talk to the nurse, and completely missed that key element of the history, and sent the patient home with the diagnosis of sinusitis. 2 weeks later, the patient came back and died of Ebola infection, and in the meantime exposed several dozen people to Ebola infection. And it's an illustration of how the teamwork doesn't exist in some settings when we rely upon, for example, the electronic medical record to be the vehicle for communication. Would it have been different if the nurse had, face-to-face communicated with the physician? Hey, did you get that history that he just came back from an endemic region in Africa? So the patient needs to be part of the team. The nurse needs to be part of the team. And finally, we need to talk about the radiologists and the pathologists who are so important in helping us make diagnoses. And in olden times, we would actually go down and talk to our radiologists and go over the films with them. But nowadays, we don't have time to do that. And the radiologist is in some different building. And all we see is the report. And that's not good. I can promise you the radiologist knows twice as much about the patient and what's happening in those imaging than what they put in the report. And if we could just reestablish that direct communication, they'd tell us about those things. And they would have the opportunity to ask us some questions, and we could convey some things that we didn't put in our request. So that's a big thing, and a simple thing that could be done to improve diagnosis is to try and make the radiologist, the pathologist, a meaningful part of the diagnostic team.
It really emphasises the importance of communication within teams. I guess we see that whenever we see something that's gone wrong, usually it relates at some stage to communication.
I think in the ER, tell us how it works in the emergency room. There's a lot of imaging done. And do they call you on the phone to relay a critical abnormality?
They do. But that has been after some incidents that they did think were as major as we did.
Yeah.
When we got the reports, we'd follow up the next day. Things fell through the cracks. So now we've got a checklist of what we think are important findings that we need to know straight away. And usually they ring up, and usually, hopefully, we've already seen the X-ray before them and diagnosed it, but sometimes we've just missed that small pneumothorax or something that would change our management.
Right. I think it works pretty well in the emergency room. It doesn't work so well in primary care. I think there's not a lot of times where there's that direct communication between the patient and the radiologist. So we need to restore that to the extent that we can. And another thing that's very worrisome to me, and I think you have it here too, we have now the ability to look at the X-ray ourselves in our offices. So we're up on the ward. So I'm not a radiologist, but I can call up the imaging on my own computer, on my own screen, and I can try and read that CT scan or that chest X-ray, whatever it is. And, even if I get pretty good at it, I am not a trained radiologist, and I'm going to miss things. So this growing tendency that we try to interpret things on our own, I think is not good for diagnosis.
So I think it's a really nice summary of how we can prevent diagnostic error, which is in some ways why we're here and why people are, I'm sure, listening today. Here's another go through some take-home messages before we get on to our next section.
Yeah. So providers, stop and think, practice reflectively, make the patient a member of the team, take advantage of second opinions, take advantage of decision support resources, follow up on your patients. All these things would be very helpful.
So I think for the next part, we're going to look at responding to diagnostic error. And I think within this era of open disclosure for clinicians, there has been some concerns about how we respond to diagnostic error. So how should, I guess, a clinician respond if they know they've made an error?
Well, I think honesty is by far the best policy. We need to be honest and forthright with our patients. They know that we're human. They know that medicine is complicated, that diagnosis is not a certainty. And if there is a diagnostic error, I think we just need to tell them, this is what happened. To the extent that we know why it happened, we should tell them about that. We should communicate that we still have their interests foremost in our minds, and we're going to try and make it right. We're going to try and understand what went wrong so that we can fix it. It doesn't happen to the next patient again. So I'm a big fan of early disclosure and honest disclosure and trying to make it right for the patient. Yeah, what do you think?
Absolutely. I mean, I think, a big part of at Avant, we have a 24/7 medico-legal advisory service. And a frequent reason for people to call and use that service is because there's been an adverse event, and whether that, to some extent includes a diagnostic error or not, the doctor may be considering open disclosure. And so, I always say to doctors, get advice. So that's why they're calling us. We would always encourage doctors to practice open disclosure. But if they've not done it before, then, talk to people that have, seek advice. I mean, very often in hospitals these days, they have sort of an open disclosure response team. So people within the hospital who are practiced and proficient at open disclosure, they've done it before, and they're able to, think about some of the finer points of how to do it. But I'd certainly encourage people to seek advice, and certainly at Avant, it's a frequent reason for people to call and seek our advice. I mean, one thing people are often concerned about, and rightfully so, is this idea of an admission of liability. This concern that, well, if I say sorry to a patient for something that's gone wrong, if I apologise that I got the diagnosis wrong, is that an admission of liability? And I think, look, absolutely, the laws throughout Australia are very clear that an apology does not amount to an admission of liability. But the other thing as well is that very often when we say sorry and when we talk with patients about what's actually happened and what's gone wrong, what we're talking about and what we're admitting maybe is the facts rather than liability. We're actually just saying, look, this is what happened, this is what I thought the diagnosis was, it's now transpired that perhaps there were some other factors that we didn't consider and now we've arrived at a new diagnosis. They are the facts, and generally if you look at the records, that's what you'll find. But I always think it's important to get advice before embarking on that process and ensuring that you have a good idea, good understanding of what you're going to say and that you have somebody there to support you through that process.
Yeah, and Owen, it's a scary thing to do, these disclosures. It's an awkward conversation, and physicians are uncomfortable doing that. And it gets to the opposite of the thing we don't want to see, which is to try and keep the error a secret. Mm-hmm. A lot of physicians, I think, sometimes assume, well, nobody will ever find out. And you're probably wrong. Probably it will be discovered, and it's the worst thing you can do to try and keep it under the carpet.
Absolutely.
So absolutely, these things need to be discussed. And just to take off on a related issue, so we'd like to be open with our patients. It would also be great if we were more open with our peers and the people that we work with. It's still an awkward conversation. But at a time when we're not doing autopsies and we're not getting good feedback about our errors, discussing errors internally would be a very powerful way to, I think, improve the diagnostic process. It would make us more alert to the possibility that we might be wrong once in a while.
Absolutely. I gave a talk recently to some medical administrators, and that was one of the points that I made in that presentation, is we do spend a lot of time thinking about how we communicate after the event with patients when something's gone wrong.
Right.
And we put a lot of time and effort into thinking about how the patient will perceive that conversation and thinking about their thoughts and feelings and emotions. And I think, look, absolutely, we need to treat our colleagues in the same way as we would treat our patients. If we think that maybe one of our colleagues has made an error, we need to have that conversation with that colleague. And I think, again, very often people worry about the medico-legal implications of doing that, but I think we also have to balance that against, what that means for that organisation's culture. If we're able to have those open and frank discussions, and also what it means for patient safety and for the community.
Yeah. And there's some tricks I think that would be very helpful in this regard. One is to give permission. For example, I work in a teaching hospital, so there's the senior attending physician, there's a more junior person, there's trainees going down. It's a very awkward thing for a junior person to criticize or raise the possibility that the more senior person made a mistake. But if the guy in charge openly at the start of the rotation says, listen, we're a team. If anybody has a suspicion that there's something that we may be doing wrong, just don't be afraid to bring it up. If you give people permission, you're more likely to get that feedback that will prevent that harm from taking place. And not just on teaching services. We'd like to see this happen in the hospital. For example, if you're in the emergency department, James, your patients get admitted, the guys on the wards are going to be reluctant to tell you if there was a diagnostic error because it's an awkward conversation. They don't want to compromise their good relationship with you.
Sometimes they're too willing to tell me. No. I think we do focus on diagnostic error, but I know when I give feedback to junior doctors about a case, it's nearly always about something they've missed.
Yeah.
I rarely tell them about the incredible diagnosis they made,
yes,
or the right ones they made.
Great point.
We just focus so much. So any discussion about diagnosis is normally always called into the office. What's this about? This is not a good conversation. So I think we have so many, those conversations are difficult because they're always negative on an error.
Good
we
point.
should be much more focused on.
So we'd like to see more feedback, both good and bad.
Yes.
And giving people permission and encouragement to give you feedback is the trick. So tell the guys on the ward that you'd like to get feedback, and you'll get more of it.
Yeah.
And that's how experts become experts. They get really good feedback that's relevant to what they're doing. And we need a lot more of that in medicine.
I think it's more junior doctors, but also maybe new consultants, they're worried about their reputation among their peers if they admit error, thinking that they may not be as good as their other clinicians. How do they overcome that?
Yeah, that's a good point. But I think if you dedicate yourself to excellence and to trying to be good and trying to get better and trying to be expert, people will appreciate the fact that you want to get both good and bad feedback. Nobody's going to be perfect. And unless you hear about the things you're not doing right, the things where there were problems, you'll never get better.
And I guess when we do focus on looking at errors, we use, I guess, things such as root cause analysis, which really predominantly look at system errors, but don't particularly look at diagnostic error. What are ways of, I guess, reviewing diagnostic error that people could use within hospitals or within their departments?
Yeah. So root cause analyses have a lot of value, and you can use different approaches. There's no right way, there's no wrong way. The way I do it is to break it down into the factors we've just talked about. What are the cognitive things that might have contributed? What are the system-related things? What are the patient-related things? And if you go through it in a systematic way, you can almost always come up with many, many different problems that came into play. The Swiss cheese model of error.
Yes.
We did a study of 100 cases of diagnostic error, and on average we found 5.5 root causes in every case. So it's almost never just one thing that went wrong. It's a combination. And it's so dependent on the patient and their disease and where they're at in their disease, whether that error will cause harm. It's just kind of a fluke thing, a coincidence that puts that patient at risk. But that's our responsibility as physicians to try and do the best job we can in those circumstances.
Do any other kind of methods of trying to, I guess, review errors that you've identified within advance? And I guess also supporting colleagues when they have made an error?
Yeah, absolutely. So I've already talked about our 24/7 medico-legal advisory service, and when we do our member surveys, our members frequently say it's the most important aspect of the service we provide to them, because it's advice that is timely. So they're in a situation, they need advice, they've got a number they can call. So that's the first way, is at that front end we help our members. Obviously we assist members with the defence and investigation in relation to claims and complaints. So when they need our assistance, we've got lawyers and claims managers that can provide that advice and assistance with a claim or complaint. We also have a confidential counselling service as well, because I think, as we've talked about before, it's important to remember that there are often two victims in this situation. So if a patient has been harmed by a diagnostic error, there's also the doctor as well, who, when they discover that, may in some cases need to debrief and talk with somebody about how they're feeling about that and what that means for them in the future. And I guess the other important aspect of our work at Avant as well is that we have a risk advisory service. So sometimes we might suggest to members, look, would you like one of our risk advisors to pop out to your practice, particularly in a private setting where doctors may be practicing alone? Would you like us to pop out to your risk advisor to your practice, and one of our risk advisors can have a look at your records or how your systems are set up, just to see if there's any systematic issues that we might be able to assist with. So they're the in brief, sort of the main ways that we assist our members.
Okay, well, thank you, Owen.
Diagnostic error.
Maybe, Mark, again, to sum up in regard to how we respond as clinicians, and I guess how organisations respond to diagnostic error, any take-home messages?
Well, as a system, we need to have a plan in place to deal with these things. And as Owen mentioned, this policy of open and prompt disclosure is the right way to go. Certainly supporting the physicians, the second victim, we call it the second victim. If you're the physician who made the mistake, you feel terrible. You've harmed a person, and it's a traumatic thing. So there definitely needs to be counseling that would be helpful in that situation, and physicians should take advantage of that. But physicians need to realize that they're not the only ones that are making a diagnostic error. This is happening to every physician every week. There's probably something that we're not getting exactly right. And just in the nature of what we do as doctors, these things are going to happen.
Look, our final session will be on learning and teaching about decision and diagnostic error. You mentioned before you would have liked maybe a medical school to have something on diagnostic error and cognitive biases. We don't have that in most medical schools. So how do medical students, junior doctors, learn about clinical decision making?
Yeah, it's so interesting. I mean, diagnosis is half of medicine, but there's no course on that. So you learn by watching how your teachers do it. And, if I'm a student and I'm assigned to the emergency department, I watch how you interact with your patients. I watch the things you do. I watch how you, think things through and come up with the diagnostic possibilities. And that, we call it the mentorship model, the apprenticeship model, works really well. So medical trainees internationally get it right 90% of the time going through that system of education. And the question we're asking today is, how do we get to 92%? How do we get to 95%? And we're thinking that when we've talked about what patients can do and providers and healthcare organizations, we think medical training would be another way to try and improve performance. So if there was a course that went through the importance of these cognitive biases, that explained all these complexities of our healthcare system and how it contributes to diagnostic error, if trainees were aware of how these errors arise, we think they'd be in a better position to help prevent them, or at least the harm associated with diagnostic error when they get out. Certainly there's things that could be taught in medical school that you don't need a lot of medical knowledge for. Cognitive biases, for example, could be done in the first year because it's all human nature. There's everyday examples of framing bias and context errors and premature closure that you could teach very early trainees. So it's easily done. The concept of working better in teams, working more with nurses, that could be done in an interprofessional manner in medical training. We'd like to see more of that. Communication is, we all take it for granted that we're great communicators. We're not. A course on communication where you learn some of these tricks and the importance of, being able to look at people and listen to what they're saying. A lot of patients say when they go into the provider's office, they'll start telling their story, and within seconds, the provider's interrupting them. Within seconds. And that's something that can be taught in medical school. Let the patient tell their story. Not only is it a way for you to get the information, but it establishes that trust and rapport that we'd like to see, that effective communication that's the key to high-quality medical care. So lots of things that could be done in medical training.
I know you give that example of the apprenticeship model, and I know I go see a patient and I make it fairly explicit sometimes what I'm thinking, because I think as a junior doctor, you see them make a diagnosis, you have no idea how they pluck that diagnosis out.
Yeah.
But there was some logic through it, and sometimes I think speaking out what you're thinking is can be very valuable to the junior doctor. The patients like it as well. It actually is a really good, in some ways, a cognitive bias strategy to try and reduce the biases because you say them out loud, a bit like writing them down in the notes, as Owen was saying before.
Well, I love that idea because a lot of what we do is subconscious, but when you start talking about it, you bring it into the realm of the conscious, and that's the beauty of having being able to check on what's going on intuitively by rationally being able to describe it to somebody like a trainee, and that's how they learn.
And I guess we look at medical education and training. So much of this is based on experience. So really just junior doctors and medical students spending time seeing lots of patients, because only then they can see the different presentations for the same disease or some of the different diseases we've described earlier.
Yeah, exactly. So the key competency that we'd like to see is being able to construct a skillful differential diagnosis. And you can't do that as a first-year medical student or a second-year medical student. It's only with practice. And you need to see, not only classical cases of, let's say, heart failure, you need to see all the variants. And the more variations you see, the more experience you have, the better you'll be able to consider that when it presents in an atypical fashion, which it, odds are, most commonly will.
And I think that sometimes occurs with people at different parts of training. You get that really junior doctor and they're very cautious and unsure about their diagnoses, but then there's that stage when they get a bit more confidence but haven't had the experience of seeing all the different presentations, and they're sometimes the most dangerous stage for that junior doctor.
Yeah, kind of an exciting thing in that domain is simulation. In simulation environments, you can create the experiences that would otherwise take years of practice. I saw a terrific program for dermatologists to diagnose, melanomas, pigmented skin lesions. And in a simulated environment, they could see 200 variations of melanoma that would take them 5 years of practice to have come to a comparable degree of experience. So I think that's part of the future, is that we'll be taking much more advantage of simulation and case scenarios to give trainees exposure to atypical variants and all the different ways that things can present.
Now, I know Advanced's done some work in regard to assisting doctors in understanding diagnostic error. Owen, do you want to describe that to us?
Sure. So I guess I suppose at the moment it's a bit of a watch this space. So as you know, we're embarking upon our claims coding project. So and we're starting to gather and analyse more and more data on our portfolio of claims, including diagnostic error claims. And so hopefully in the future we'll be in a position to have much more information about the different types of diagnostic errors and some of the underlying causes of those errors, and then be able to, when we identify those trends, be able to sort of target our members with some education in those areas. And certainly today is a start with that, and I think engaging with experts such as yourselves is the first step in that process. We've identified that it does make up a large proportion of our claims, as I said before, about 10% by number and 25% by cost. And so that obviously, is a significant, number of claims, both for us but also for our members and for the community. So it's an important area, as we've said, so it's something that we're keen to be involved in.
I think that's a very valuable service that you provide, Owen. If for example, if I'm in GP practice, if I see cases that happened in another comparable practice, it's like a wake-up call for me. This could happen in my practice, and it's a great way to learn.
Okay, so I think we've had a nice summary of some of the issues around learning and teaching of diagnostic error. Any take-home messages for this session, and I guess as a general close to our discussion today?
Well, so the key to being a good doctor is just to know everything, and we all know how impossible that is. So I think the take-home message is to learn also about how these diagnostic errors arise, and it should be part of the education process, and that would produce better doctors going forward.